shall now go on to our next speaker, Dr. Suresh Pandey, who is the founder of Subi Eye Institute and LASIK Center from Kota. Again, a brilliant surgeon, and he's going to show you a very challenging moment which he has dealt with. On to you, Dr. Suresh.
Thank you very much, Dr. Chitra ma'am. And first of all, I would like to congratulate you and entire team for organizing the beautiful AIOS ARC top pulse in the cataract surgery. And today I'm going to show two different cases of phacoemulsification postural disorders. Sometime we encounter situations like this. 56-year-old gentleman who has a history of congenital thoracic kyphosis, and he is unable to lie flat on the OT table. This gentleman presented to us with the cataract in both height, and most of the surgeons were not very comfortable to perform surgery of this gentleman. We took him in the OT. We did the mock drill, and this surgery was done in the year 2010. So we have just asked him to lie down sit on the table, and the surgeon took the standing position, and you can see here the capsular access is being done, and we used the basic 1FR Zeiss microscope, although the mounted CD microscope can be helpful in such cases, and the surgery was little difficult and challenging because of the unusual position of the patient and this standing position of the surgeon. Here I'm doing the surgery with my left hand, and you can see the incision was made on the temporal side, and I'm using my right hand to chop the cataract. The entire surgery was uneventful, and we did the irrigation aspiration, and this was followed by the implantation of a 3-piece intraocular lens into the capsular bag. So many times we face this situation of phacoemulsification in postural disorders. Patient of kyphosis, Meniere's disease, COPD, or ankylosing spondylitis, etc. They come to us and they are unable to lie flat on the OT table. So in these cases, it's important to do the mock drill, explain about the possible complication to the patient, and to explain surgeons should take these such cases. And once the surgery is done, luckily we were lucky enough that there were no complications, and the case went very well, and the patient regained 6/6 vision in the post of unaided, and with the plus 2.5 that addition, the near vision was perfect and 6. And here I'm going to show you another case of 55-year-old female. She was a case of cardiopulmonary disease, Meniere's disease, and obesity. So we used plastic chair to perform the surgery. Here the patient is seated on the plastic chair, and her feet were extended, and she put her feet on another chair. And we used the support of the surgeon's stool, and so her neck was extended, and she was looking towards the roof of the operation theater room. The surgeon once again took the standing position, and here you can see the surgery is being done. This is the capsular access. And the difficult part was that you cannot use both your feet while performing surgery. So what we did, we just asked our assistant to use the foot switch of the OT table to make it up and down. We fixed the microscope, and we made it in focus. And then we used the phaco emulsification machine to emulsify the cataract, and we used the 1 foot on the foot table of phaco machine, and the patient surgery went very well. We implanted the technique multifocal lens, and the patient regained 6/6 and 6 vision. And it's a very difficult scenario. Sometimes we do encounter cases of hyperemulsification postural disorder. It is very important to do the mock drill and explain about the pros and cons, and then take these cases. Thank you very much.
Thank you very much, Dr. Suresh. That was an amazing video which you showed. But I just wondered, so especially in the first case, if you keep a lot of support in the lower back, you could make the patient lie down so that the head is in a more near normal position. You can sit and operate. Because I don't know how you could give a foot pedal to your assistant and operate. I mean, it's phenomenal first, very difficult. I don't know. I'm hats off to you for what you did.
Chitra, can I make a comment?
Yes.
I would agree with you because I've done a couple of kyphosis patients, wherein what we do is we just elevate the foot end of the patient. We stand backs and we used to elevate the foot end so that the legs, the feet will be vertically facing onto the ceiling, so that automatically the head end comes down. So that makes life easy. Otherwise, it's very difficult. I've also done surgeries wherein the patient is not able to lie down. I've done in the sitting position. The only thing is you need to orient your microscope. The tiltable optics are there with all the newer microscopes, the higher end microscopes can have. You can just tilt it like that and you can use it as well, but it's a little more difficult. But raising the leg end makes more sense actually. You can get the,
Yes, Dr. Mohan Rajan, I think that's very important point you have mentioned here. And this case we did in 2010. So that time, like we just have, it was the first case. So we were trying to figure out the best way. And this is, I think your suggestion is wonderful. And you can use the high-end microscope and you can use the table, to take its advantage so that you can manage these cases nicely.
Dr. Malay, you want to add something? Dr. Malay, we can't hear you, or my.
Hello, can you listen?
Yeah, yes.
Listen. Yeah. Hello?
Yes, we can
Am
hear
I audible?
you.
Yes.
Yes, so I fully agree with Dr. Mohan Rajan. You see, we have seen these patients and you keep if the hunchback is like this, if you rotate it like this, the leg end goes up and the head becomes horizontal. It is easier to operate when you're sitting. So surgeon's comfort is also very important. And you have to remember that suppose it's not about heroism of the surgery, but predictability. And predictability definitely goes up when the surgeon is sitting. So I think that point is very well, it has to be understood. And you don't need a high-end microscope. OPM1FR is a fantastic microscope to operate with, and posturing, as has been mentioned by Dr. Mohan, is a very good idea we have done. We have raised the leg end and made the head horizontal. A bit of intraocular pressure related issues come, but if you're careful, then you are able to handle it. And
have you also, all of us, yeah. I think all of us also need to remember that these patients could need an anesthetic standby when you're operating. They could have some cardiopulmonary.
Because their heart will not be normal. We should
play it safe in the present day. Yeah.
Absolutely.
Yeah. Wonderful, Dr. Suresh, and really